All right. Good morning. I know it's such a beautiful day, you'd all rather be outside in the rain. All right. So, November is PCEP. We are going to talk today about infectious diseases. Recall that every 3 years we do the complete cycle of paramedic refresher. That way you can qualify for the 40-hour refresher every 2 years for National Registry, as well as if you attend the PCEPs and do your or do the makeup if you can't be here in person, you will qualify for automatic OTEP requirement for your recertifications. So last time we gave this was almost exactly 3 years ago. I mean, not the exact same lecture, just because it is updated. We did check a few things. So we talk about infectious diseases. Microorganisms come in all sorts of flavors. Normal flora, I mean, we are surrounded by bacteria, viruses, little protozoans, things like that, but most of them are perfectly happy and get along with us just fine. So normal flora, you've got bacteria in your skin, which is why we get things, why we can infect things from your hands. You have normal bacteria in your intestine. Obviously, the intestine is just full of bacteria, but it doesn't hurt you. As a matter of fact, you can't have a normal colon without having normal bacteria in it, because you will die if you don't have normal bacteria, because they help your digestive thing. They're sort of they're sort of saprophytic critters, and they help you digest food and keep your intestine safe. So pathogens, though, come in flavors of bacteria, and the common ones we know is staph, strep, like beta hemolytic strep, which causes sore throat, and then has the effect of getting the building an antibody to it, antibody reaction. You end up with either glomerulonephritis, rheumatic heart disease, etc. The enterobacteria are the intestinal bacteria, and they're, like I say, normal good ones, and then there's bad enterobacteria, such as salmonella. Viruses, we're going to talk a lot about viruses. Rickettsia are unusual organisms, but think of Rocky Mountain spotted fever as a rickettsial disease. This thing? The mic. Okay, he says it's too much. Protozoans, Giardia, things like that. And then there are opportunistic pathogens that take advantage of you when you're immunosuppressed, particularly things like funguses and things. Common bacterial diseases include things like sinusitis, otitis media. Those of you who have children that were born, like me, the children that were born 50-some years ago, we always treated otitis media. It was considered to be a terrible bad thing. Nowadays, you hardly treat otitis media unless there's a problem with hearing, or a problem with a really high fever, and you're worried about things like meningitis. Pneumonia, bacterial pneumonia, very common. The strep pneumonia or pneumococcus pneumonia. We like strep pneumonia and pneumococcus so well, we gave two names to the same bacteria. Most common type of pneumonia, particularly in the elderly and in the very young. Pharyngitis, mostly the ones most pharyngitises turn out to be viral, but everyone worries about a strep throat. Tuberculosis, we'll talk at greater length, but it's a unusual, very indolent, meaning a slow reacting bacteria. Possibly the slowest reacting bacteria we know is the bacteria that causes leprosy. It's extremely lazy bacteria until you get it. Bacterial growth is pretty fascinating because, get rid of that. There's a lag phase. So you cannot get infected by one bacteria. It just doesn't happen. So you need a couple, you need anything from probably 10 to 100 bacteria to actually get going, because it takes a while for growth to get going. They have to get used to the new climate they're in, the new host. And then, so in the lag phase, those 10 bacteria may hang around for a day or so trying to get used to things, and then it'll take off. Once they're used to where they are and they're used to the food stuff and they get going with it, then it's just an explosive thing. It's called the log phase. And so if you have 2 bacteria, there are 4 bacteria. Then those 4 bacteria become 16 bacteria. Then those 16 bacteria become 16 times 16, which, as I recall, is 256. And it goes like that. It's just an explosive growth. Until they get to a stationary phase, as they get so many bacteria that are competing for food and nutrients, and then growth slows down because they can't keep running the machinery. When you get into the millions and billions of bacteria, they're going to run out of food. And then, just like any big city that doesn't have a sewer system, the toxic waste products build up because they put out toxic waste products too, and then they start dying. So then it just lags off and they start dying. Now, one of the best examples of what staph is one of the bacteria that really shows how that occurs, because characteristic of staph infections are abscesses. So you start with a little sore, and then it begins putting a little pus into the center. The pus is dead bacteria and macrophages and the waste products of the bacteria, and then this keeps getting more and more and more until it totally runs out of foodstuffs and the bacteria. So a really big pussy abscess is not very active. The stuff from the center is already dead. It's not really infectious. Just a big bunch of dead old bacteria. We characterize bacteria by how they pick up, how the cell bodies pick up stains, and the gram stains come in a blue one, and then an eosinophil, which is a red color. Some bacteria pick up the blue. We call those gram positive. Some pick up the eosinophil, the red, and we call those gram negative. That's just, we could have flipped it around, but that's the way we did it. Then we further characterize them as the shape. So round bacteria are called cocci. Round bacteria that come in 2 at a time are called diplococci. And so, for example, if we look at a gram stain, if you bring a patient in that we think has meningitis, and we do a spinal tap, and you make a smear of it and you stain it with gram stain, what we're looking for meningococcus is gram-negative diplococci. They picked up the red, and we see these little red things. And if we see that, we're going to call you and say, okay, if there was any exposure, you guys need to have some prophylactic treatment. Now, we'll talk about meningitis as we get there, because there are some things you need to worry about and some things you don't need to worry about. Rod-shaped things, so long, sort of cigar-shaped things, are called rods, the bacteria, and they can be gram-positive or gram-negative. E. coli is a rod. It's a gram-negative. There are some bacteria that are spirochetal-shaped, or that are spiral-shaped. The spirochetes, the classic spirochete is syphilis, but also another spirochete, which isn't quite as scary in one sense, is Lyme disease is a spirochete. And now, some bacteria produce significant endotoxins. Those are primarily the gram-negative. So you commonly see when you have somebody in sepsis, a lot of times the old thing, especially if it was from a urinary tract infection, which is usually, at least in the elderly, it's usually an E. coli or a similar gram-negative bacteria, that we say they are in gram-negative shock. It's endotoxin shock. It causes blood pressure to drop. It causes heart rate to drop. It causes sepsis by itself. It's released during cell destruction. So sometimes when we start treating people who have a urinary tract infection, as you kill the bacteria, you can accidentally get a gram-negative shock. Another endotoxin, and then there are exotoxins, which are on the outside of the bacterial shell, and a common exotoxin, which doesn't cause shock, it causes a reaction of you. A common one would be the exotoxin from gram-positive bacteria, from staph. It's the thing that causes staph food poisoning. Common food poisoning, you get a staph infection, staph infecting, let's say, potato salad, or some sort of a creamy substance. It's a food. It's not stored correctly, and the bacteria multiplies in that new food stuff, and it puts out an exotoxin. Now, when you eat the food, you do not get the infection, because the staph is killed when it hits your stomach acid. But the exotoxin causes you to have terrible nausea, vomiting, and diarrhea about 4 hours after ingestion. It's the exotoxin reaction. Viruses are called obligate intracellular parasites. They are parasites. They do not have the metabolic mechanism in them to produce their own foodstuffs and to reproduce. So they hijack your cells and use your cell mitochondria and mechanisms to reproduce and also to feed themselves. And when they're done reproducing in that, they leave and go off to infect somebody else. Well, few of them do. The rest cause you to become ill, and then they die too, unless you do. So they grow and reproduce within the host cell. Virus replication is even more incredible than bacterial replication, because when they hijack your cell, they really work it. And they can do an amazing, they'll go from a few viruses to billions in 24 hours. Other microorganism, prions, well, it's not too common. A prion disease is mad cow disease. Prion is even simpler than a virus. We don't really know. It's like a piece of a virus. And it's also, so mad cow disease is the most common. There isn't a great deal of that around anymore. We don't see any kuru. Kuru is the thing that the New Guinea headhunters got from eating somebody's brain, and then the revenge of the eaten happens about 20 years later. Fungi, yeast, most of the time they don't bother us. They bother us when we have low immune systems. So people with HIV, with AIDS, actually would have are more prone to severe fungal infections. Little babies will get yeast infection from mom during birth, and because they have they don't have an immune system that really knows anything about yeast and fungi, they can get thrush in their mouth, which is a yeast infection. A lot of us have things like athlete's foot and toenail fungus. That's a genetic predisposition, which is so you don't have resistance to that particular type of fungus. Parasites, there's several different kinds of parasites. Protozoa, giardia, which is beaver fever. You get it from the mountain beaver going into your water supply, and when you're out there sampling the Rocky Mountain high water, you end up getting a little giardia, which causes a fairly significant diarrhea and intestinal problem. Entamoeba, amoeba, common in less developed countries. Worms, helminths, so pinworms, hookworms, trichinosis. So there's some specific worms that are characteristic of Southeast Asia as well that they get from poorly prepared food. Trichinosis almost exclusively doesn't exist in the United States and in developed countries that do not allow you to feed swine garbage that's not been treated. It can only be gotten by meat-eating animals. So the big thing with trichinosis is, people, bears, and pigs. People that are omnivores, particularly, or things that are omnivores. Ectoparasites usually don't cause them. They're usually vectors. So lice, mites, bed bugs, etc. Icky little creatures, but they're not bad in and of themselves. They are just usually a vector of something else. So, how do you get a disease? Well, there's a interaction between the host, the infectious agent, and the environment, which is, which varies by the bacteria, varies by the time. So there are certain reservoirs of certain bacteria, such as although we don't see a lot of plague anymore, at least in this country, plague still exists, and it's in the wild. And so rabbits and some other rodentia are the host for things like the plague, things like tularemia, things that you probably haven't ever even heard about, and you certainly, but in some parts of the world, plague is still common, and it's the same kind of host thing. So during the great plague epidemics of the Middle Ages, rats were the host. The rats were the reservoir of the plague, and the plague was spread initially by you being bitten not by a rat, but by a flea that came off the rat. And then you became the new reservoir for that. And the interesting thing about the plague is that it can become airborne from an infected human host. And then when it's airborne, you're in trouble. But in the Middle Ages, they also had lots of rats. It seems only fair that, well, they had lots of rats and, of course, lots of fleas, and the fleas would go back and forth with people and stuff, so they would just keep spreading the disease, too. During the Middle Ages, they also thought that cats were the minions of witches, so they killed cats, and so, of course, they got more rats and more flea and etc. So it seems to be kind of Mendelian or somehow related to survival of the fittest there. Now, there can be direct or indirect transmission. So bloodborne, airborne, a bacteria that figures out how to be transmitted by food or by sex is going to be pretty successful in staying around. It always has a way of transmission. So fecal-oral route, foodborne. Now, there is a theoretical risk of infection versus the actual measurable. What we measure in public health is the actual rate of an infection. The theoretical rate is almost always much greater because we're not smart enough to figure out all the possible permutations. For example, when we had the big H1N1 pandemic flu scare a few years ago, it was a real problem. And the theoretical was very scary. The actual and the measurable turned out to be much better because we just lucked out on that one because it mutated after about 3 months and became a very docile organism. Luck. Factors affecting disease transmission. How did it get into you? Well, so if you have something that has to be injected, it usually takes more quantity of bacteria or viruses than if it's airborne. Although airborne, when you get a droplet dispersal, you get a lot of bacteria, a lot of viruses in a droplet. So the number of organisms transmitted, like I say, you cannot get an infection from one virus. You can't get an infection, literally impossible, because it probably won't survive. You need a little bit of a number to get going. Does the host have resistance? Are you immunosuppressed? Are you a child and you haven't yet been exposed to that particular types of bacteria, so you haven't got any resistance? Your other host factors, your other resistance factors are not there. People, of course, with leukemia, with other suppression of their immune system would be very likely to get infected. So an infectious process usually has a latent period where you've got, let's say you've got enough, taken in enough bacteria to become infected. You're not infected day one. It takes a while. It takes a while for that lag phase to start producing enough bacteria. Then you'll end up into, so we'll start down here. So you got an exposure. Then you have this latent period, which is your incubation period, essentially. And the latent period is where now we're in full viral or bacterial production, and it goes on very, for quite a long time, for quite a while. And then you are actually infected about, and you start to be contagious. When it says infectious period, that really means contagious period. You're actually contagious because your infection is going on without you showing clinical disease. The first few days of your infection, you do feel bad. You let's say the common flu virus, you get exposed, you have a latent phase, early incubation period of about 2 to 3 to 4 days, and about 4 to 5 days into it, you start feeling achy, you have a runny nose, you have maybe a sore throat, all those things that go along with the flu, and then you feel really bad. Unfortunately, it's the way these things. Unfortunately, you're entirely contagious about a day before you start showing symptoms, which is why, and the same thing works with almost all viruses. So, chickenpox is contagious before the person shows the first pox. Measles is contagious before you get the first signs and symptoms of measles, and certainly before you get a rash. So here you have this one person who now is infectious, contagious, and not showing any diseases, and they're transmitting it to whomever. And so you can see that if they came in contact with 30 people in that time period, they probably have been able to transmit it to maybe half of that. So you get this upper bar here, you've got 15 of these going on. So you're starting to branch out. And that's how epidemics get going, because this one will go through the incubation and latent period and be infectious, contagious at the same time before their disease comes out. So they just keep spreading it. Okay, how do we fight against diseases? Because they're all out there. Well, barriers to entry, intact skin, and your respiratory system is full of mucus, which traps bacteria and viruses, full of things like macrophages and things that are set up with part of the immune system and part of the fight system to kill viruses and bacteria. So they will start to grab these things. So your respiratory system and your intact skin are the usual barrier. Now, there's a slight barrier for certain things getting into your intestinal system, because stomach acid will kill most bacteria, but unfortunately not the pathogenic bacteria and the viruses. No, then the immune system backs up that initial barrier. So the reticuloendothelial system identifies So your immune system identifies foreign material. Foreign material is antigen of most bacteria and viruses, and then the RES system starts a inflammatory response which is designed to entrap and kill that material, that foreign material, that virus, that bacteria. It includes leukocytes, neutrophils, and macrophages, which are the big, they gobble up bacteria. There's a picture up in the corner. There's a macrophage, and you notice he stains mostly red, and he's gobbling up a streptococcus. Cocciforms that are all stuck together. Streptococcus pyogenes is a intestinal strep. Then there's cell-mediated immunity. Certain cells, such as the macrophages, will have specific killer immune sensitivity for certain bacteria that they've learned to go after, basically. Then there's humoral immunity, which is circulating in the plasma immune antibodies which have memory for a specific virus, a specific bacteria, and specificity for that virus only. So when you get a virus disease, such as measles, you get the disease, the measles are gobbled up by macrophages, and then with an intact spleen and intact lymphatic system, your immune system creates an antibody that is specific to measles. Then the next time that you're exposed to measles, the macrophages identify it really quickly, gobble it up, and then the immune globulin immobilizes it and starts to kill it until the macrophage can eat it up. And you don't get the disease. Once you get a virus disease, you can't get that disease anymore. And you say, well, okay, Smarty, how come I can always get the flu? I get so many different, it's because the flu, unlike measles, which is a very specific virus that doesn't ever seem to mutate, there are so many different subvarieties of the flu. There's probably thousands of varieties in H1N1, H1N2, H2N1. They go on and on and on. And within each class, there's many, many potential mutations that each time you have to be exposed to that specific one. Then you'll get a specific antibody that won't let you get that one ever again. And that's how we've come up with the flu virus, which is not as accurate, not as good as it could be. Now, the antibodies, there's IgG, IgM, IgA, IgD, IgE, but they're all part of the immune antibody system. And the antibodies can be in any one of those type of immunoglobulins. Now, autoimmunity is when you've accidentally, there's a slight glitch in the system, and you've built up an antibody to your own antigen, your own tissue. So an autoimmune disease would be something like rheumatoid arthritis, where you've built up an antibody to your own joint cartilages. Or severe eczema, where you have an antibody to your own skin. Complement system is another part of the defense system. It's a rapid response system. There are proteins that work along with antibody formation and with the reticular endothelial system's anti-inflammatory reaction to fight infection. So it's a little booster for the immune system. We've tried, for years, they've tried to get ways to boost the complement system for people as a way to avoid illnesses, but we've not been very good at it. Now, you do that yourself. For example, when you've probably heard people say, or you've probably thought it yourself, that, it's a good thing I had a cold last week because there was a flu going around and I didn't get it, or something like that. And that's probably true, because when you had the cold, that was your complement system ramped up in response to that cold, and then it's still ramped up 2 weeks later. So you're probably less likely to get two diseases in a row. Complement system also recognizes endotoxins of certain bacteria, such as Shigella, such as Salmonella. So it helps to fight that off. Lymphatic system, the parts of the lymphatic system: spleen, thymus, lymph nodes, and then of course ducts. They collect and filter lymph. They also collect all these macrophages and other phagocytes that are circulating in the blood and circulating ultimately in the lymph. They collect them, and that's where you start to process and produce antibodies, and where you start to build up complement. So much so that when someone is asplenic, they've lost their spleen because of a car wreck, and we've had to remove their spleen because they were bleeding to death from it, or someone who's got like sickle cell disease and their spleen is destroyed over a period of time because of the sickle cell disease. They're at big risk for certain things such as pneumococcus. They can't mount a defense against pneumococcus, and so if they get pneumonia or get a pneumococcus, they'll go right on to sepsis. Then there's individual host immunity. So at birth, you were born with you're blessed with most of the maternal antibodies to most of the viruses and most of the bacteria that the mother has ever had. So if the mother has been immunized against tetanus, you don't worry about babies getting tetanus. That's why we don't start doing tetanus immunizations until about 3 to 6 months of age, because they have maternal antibodies that last about that long. But just like getting a shot of gamma globulin, it's a passive immunity, and it's going to disappear as that antibody, which is a protein, gets processed through your spleen and liver. That's what happens. So active immunity is when you actually get the disease, or when you're immunized against it, when we get a shot that immunizes you. Now, when you get, if you haven't had tetanus and you get your immunizations, then you will seroconvert, which means that we can test for antibodies. We'll do an antibody titer against tetanus. And we don't bother doing that because that's expensive, we know, but we've done enough experimenting with it that we know that your antibody, once you've had your 3 shots and a booster, your antibody to tetanus is good for a minimum of 10 years, probably longer. Titers are expensive, and you know, it's much easier just to get the booster. We know you're good for that time. Oh, this is a very complicated thing, and I think I can avoid this. It's just say how we try to do infection control pre-hospital or in any hospital or any kind of control is to go for the either minimize the infectious agent, which is sometimes difficult, attack how this agent is transmitted. So if you have a virus that's transmitted by hand to mouth contact, droplets on surfaces, then you go after that transmission, and you have people wear gloves. If it's done by airborne, you have people wear masks as a way to stop that transmission. So if it's foodborne, you deal with managing food. If it's the host, you can increase their host resistance. So what we do is we try to go for it. So when we've come up with a plan to manage your exposure to the flu, you do it by minimizing your exposure, then minimizing your exposure to the airborne and to the droplets off a surface into your mouth, and then you get a flu vaccine. So you have all those things going on at the same time. There is a training requirement under the WAC. By the way, has anybody ever noticed how many WACs there are? There are an awful lot of WACs. Yeah. There's the story of Moses coming down from the mountain during the and the fog is out there, and he comes out and he's carrying the tablets. This is Moses. What are those? He says, well, those are the 10 Commandments. The wind comes up, blows away, and there's thousands of tablets up on the mountain. He says, what are those? He says, those are the WACs. Okay. So the WACs, there's a lot of stuff in the WACs about infection control, as we'd expect. It has to occur, your training has to occur before you get assigned tasks where exposure might, it has to occur annually, which is why we do this partly. Has to have additional training for changes in protocol or PCPs that will affect occupation exposure. You have to have written procedures for infection control, have an infection control plan, adequate infection control training, easy access to personal equipment, ensure that all personal wounds are bandaged and treated before responding to an emergency. The other thing is you shouldn't, if you feel sick, you shouldn't go to work. Use disposable supplies and equipment whenever possible. You have to have access to personal hygiene on the rigs and at the stations. Don't allow infected personnel to deliver patient care. Don't go to work when you're sick. Monitor EMS personnel for compliance with vaccinations and diagnostic tests. Now, we can't force you to get certain immunizations. But you have to have a reason not to. Appointed designated infectious disease control officer. Identify jobs where possibility exists that we identify situations within all of you where it could be exposed. So we have situations which are high risk. Provide hazmat education. And when you respond to, obtain as much information as possible from dispatch. Yeah, I know sometimes that doesn't help. Prepare for patient contact. If you know you're going to a place where someone is really sick, don't everybody rush in. Prepare mentally for the call. Send the lowest level partner in. No, that's when you make patient contact, isolate all body substances, wear appropriate PPE. So gloves and eye protection on all calls, masks when you have splashes, spray, droplets possible, respiratory illnesses, a bloody face, a trauma patient. When you're going to do an intubation of that bloody face guy who's then going to spray stuff at you. Patient is sick and the resident of a sniff. Because a lot of them don't tell you when they have MRSA, when they have methicillin-resistant staph. A lot of them don't tell you that, oh yeah, the 5 people down the line are having diarrhea too, so they've got a norovirus outbreak going on. So you can stop all your exposure by wearing stuff. Allow only necessary personnel to make contact. So when you have a high flu thing, if you have a real risk of an infection, don't bring everybody in the room. Just, the people who are in the room get to gown up. If you don't need more help, don't bring it in. Don't expose more people. Use airway adjuncts. Use disposable items whenever possible. You have to properly dispose of your sharps, biohazardous waste. Don't smoke, eat, or drink in the patient compartment of the ambulance or the rig. Don't apply cosmetics or lip balm or handle contacts when you've got the possibility of an exposure. The eye is actually a very good absorptive area. We give, there's a reason eye drops work because they're absorbed. So are other things. Wash your hands immediately after patient contact, and I think still washing is better than using the bacteriostatic stuff. If you sustain a wound or exposed to body fluids of others, wash the wound with soap and water immediately, and then the whole process will go through. Dispose of your biohazards properly in leak-proof biohazard bags. Bag and label soil linen, decontaminant, contaminant clothing, and reusable equipment. Uniforms, there'll be an agency policy for that. Now, routine cleaning doesn't destroy tuberculosis, for example. So low-level disinfection, there's a lot of things to get by it. Intermediate level disinfectant, which is 1 to 10 water and bleach, or bleach and water, it's the other way around. That destroys TB, most viruses and fungi, but not spores, not tetanus, for example, which is in a spore form. High-level disinfection destroys all microorganisms and almost all bacteria, and sterilization gets it all. True sterilization. Autoclaving, some chemical immersion agents, to read the labels. Okay, I'm going to do a couple things before we have a break. Infectious disease of concern to you. I mean, most of those things are not. We can talk about special things afterwards on the side if you're really worried about other infections. So, human immunodeficiency viruses. We have been dealing with this one now since probably about 1980. I remember trauma people not wearing gloves when they're examining a head wound in the late 70s and early 80s, because they said, well, I can't feel the fracture as well with gloves on. You don't find that anymore. People wear gloves, and before they examine the head wound, they probably do a CT scan. But then all of a sudden, HIV popped up, AIDS popped up. It's due to what's called a retrovirus, because it does a reverse transcription, which is what it's called, reverse transcription of its DNA or RNA when it's making itself. It's found in blood products, and body fluids. So common methods of transmission: sexual contact, shared needles, or accidental injections. For healthcare workers, it's rare to get the transmission, not unheard of, but rare. Accidental needle sticks are the most common, and it takes probably a minimum of 1 to 2 cc's of actual injection, because there's not that many viruses in 1 cc of blood. And 1 drop of blood probably doesn't do it. You could be unlucky and be the 1 drop, though. High-risk exposures, those involving large volume of blood, deep percutaneous injury, actual intermuscular injection, or a really high antibody titer in the source patient. Clinical presentation of the initial presentation of HIV is just like most viruses: fatigue, fever, sore throat, swollen glands, sometimes splenomegaly, sometimes rash, diarrhea. You know, gosh, that's kind of how hepatitis looks too. Kaposi sarcoma is an unusual skin cancer that comes and goes. It gets worse. They get more spots as the disease progresses, and it's usually not something that shows up until you actually have AIDS, immune deficiency disorder. People are particularly prone to things like, because their immune system is suppressed, they're prone to opportunistic infections from funguses and other parasites. Extreme weight loss is common. Dementia, psychosis, peripheral neurologic disorders develop as you get further into the actual acute immunodeficiency syndrome. Now, if you think you have an exposure, the hospital, both hospitals have a protocol for it. Now, I will be the first to say that it happens so infrequently that, and the charge nurses and the nurses turn over fairly quickly in both ERs, that half the time the charge nurse won't know what to do when you come in. You'll go in with a supervisor, or have a supervisor call and say, okay, we've had an exposure, and this person needs to be tested. You don't need, the source patient needs to be tested. You don't need to be tested at that point, because we don't know that there's any issue. But you have a source patient, and if they don't seem to know what's going on, tell them, you have a protocol in your protocol book. Look it up. Okay. What they do is draw blood from the source patient. and do a rapid HIV test. And they will also send that blood off for a confirmatory HIV test for hepatitis B, for syphilis, and a couple of other things for good luck. But those are not going to come back right. The rapid HIV test comes back in 2 hours. If it's positive, you're in deep dog doo. No, not really. But if you're positive, you have to do something. If you're negative, you're fine. And you wait for the rest of the test to come in. Now, you already should have been hepatitis B immunized. You already should have. You should also. You should not have any major risk. If you have a positive test, then within probably 2 to 6 hours, you need to start. You need to have a medical evaluation, face-to-face with a doctor, and then they'll start you on, if they think this is a real exposure, then you need to start either triple, or nowadays they have a double therapy, two medications in the same pill, or three different medications all at the same time, and that goes on for probably 2 months. The reason you have to have the medical evaluation is because we have to make sure yes, indeed, this is really a true exposure, because there are, of course, with every other medication, there's the downside of it. Although the double therapy right now is very, very low side effects. You need post-exposure counseling, that's all. But I mean, the sequence is very simple. The source patient needs to be tested, which is why it's important for you to go in quickly, so that the source patient is still there and being evaluated. And if they balk at it and say, well, we can't get permission, well, just the trauma surgeon, and a lot of these are mostly trauma patients, the trauma surgeon will always order that for you. HIV rarely presents life-threatening challenges, but the psychological issues of it are pretty big for you. So take appropriate precautions. Most of the time, you should not have an exposure unless it's a true accident. The exposures we've had were people who got sprayed, whether they didn't have a mask or goggles on, and they were intubating a trauma patient. Turned out that in those cases, these were negative rapid HIV. If you got to get exposed, this is not a bad community to get it, because we don't have a lot of HIV. I don't think I've ever picked up a positive HIV in the source patient in the 25, 30 years I was at Southwest. A lot more hepatitis B, which is why you can get immunized for hepatitis B, and you have to do that. Now, so what a segue, right? What a segue. We'll go right into hepatitis. General signs and symptoms are almost similar, no matter what kind of hepatitis. It's just the duration and the sequelae of them. So symptoms of the initial infection are headache, fever, weakness, joint pain, back pain, anorexia, nausea, vomiting, sometimes upper right quadrant abdominal pain, because your liver lives in the upper right quadrant. So a virus illness starts out as almost all virus illnesses. Then as you develop hepatitis, you get jaundice because your liver isn't processing blood and hemoglobin normally, and you're producing bilirubin. Bilirubin, the soluble form of bilirubin, is the part that comes out in liver bile, and that's what makes your stool brown in color. So when you don't have soluble bilirubin coming out in the bile, you get whitish clay-colored stool. Well, that in and of itself isn't very exciting. It's interesting to note. But the less soluble stuff then becomes is circulating in blood, and it turns you yellow in color, jaundiced. Shows up first in the sclera, obviously more difficult to see in dark-skinned persons. And then it is removed by the kidney, so you start getting this bilirubin material in the urine, so your urine turns dark. So you've got a reverse of stool and urine in color, and you're yellow besides. Hepatitis A, infectious viral hepatitis, is transmitted purely by fecal-oral route. It's mild. Many patients are asymptomatic, which is why it was a very successful virus, because it had lots of carriers. Usually it was a little kid gets it, comes home from school with it, and then infects the entire family. It's rarely serious, lasts 2 to 6 weeks. Used to be very common in the 40s and 50s when I was a kid growing up. That's the 1940s, not the 1840s. But it was very, I remember one year in my class I had like 6 or 8 kids out with hepatitis, and their family, their parents were sick too, and it didn't kill them, they lost work. I don't think anybody hardly ever died of hepatitis A. Hepatitis A is much less common now thanks to dishwashers, because it sterilizes your dishes and your stuff, and it's a fecal, it's spread through foodstuff and fecal contamination of utensils and dishes. So there was a big push, and that's also when in the United States all the restaurants began having all this wash your hands, those signs that say wash your hands after using the bathroom. That's a leftover from the hepatitis thing, and then you had to go through a 3-stage sterilization of dishes in restaurants. Hepatitis B or the HBV, transmitted through direct contact through blood, semen, vaginal fluids, saliva. It's significantly higher risk for EMS providers, much more so than HIV, because it's prevalent, it's common. 5 to 35% of all needle sticks result in infection, and it depends on where you live. If you were in inner city Detroit 20 years ago and you got a needle stick, you were probably 50% chance of being exposed to hepatitis B. Hepatitis B was so common in EMS and medical workers that of course, we came along very quickly with the hepatitis B vaccine. Hepatitis B is it's very nicely. Usually, it only requires the three shots, and everybody gets a really good titer. It takes a shot gets to start the immune system, another one to boost it, and a third one to finish off the boost. So all EMS workers, all medical workers should get vaccinated. Because remember, 60 to 80% of infected individuals are asymptomatic. Hepatitis C, primarily transmitted by IV drug abuse and sexual contact, but also by needle sticks and exposure to EMS and medical workers, any body fluid exposure. It's a chronic infection, It can cause active disease years later, and it's associated with the development of malignant hepatomas, hepatic cancer. It can cause cirrhosis as well and end-stage liver disease. And nowadays they have treatment that's almost 99% curative. I've known at least 4 firefighters who have had hepatitis C and have been cured. So it does happen. Hepatitis D only exists concurrently with with HBV. Hepatitis E is transmitted by contaminated drinking water, so it's sort of like it's a oral oral transmission, and it has pretty much the same. It's not very exciting. Can you hear me? Can you hear me now? Okay. So, other diseases of concern to EMS providers. Tuberculosis. Tuberculosis is the most common preventable infectious disease, and it's prevented by avoiding it, by treating others and avoiding it yourself. Nowadays, we have drug-resistant tuberculosis. We can thank a lot of developing countries for it, and it's another thing to thank the old Soviet Union and current Russia for it, is because they don't treat people who are in prison there, and they get some significant drug-resistant tuberculosis. They don't adequately treat them. Now, skin testing. We've all been skin tested for tuberculosis. It is not recommended. The CDC does not recommend yearly testing anymore. They recommend testing at higher, and then testing if you have a possible exposure, or if you have any symptoms, of course. But it is not recommended because there's too many false positives, because the skin test, the old tuberculin skin test, where they put a little wheel of the antigen underneath your skin and then see if you have a reaction to it, that is actually antigenic in and of itself, and so that can produce a false positive. There is a thing called the gold. It's not, I misput it. It's not called the GOLDS. It's the GOLD test, and it is it's a blood sample, and they do an immunoassay for the antigen. Now, it can't determine between a latent infection and an active infection, but it is extremely accurate. It's very, very specific. Like it's 99% specific for that antigen. So if it's positive, so if you ever get a positive skin test, we would order a gold test after the fact to see if you really have it or not, rather than starting. That used to be that if you had a positive test, we would do a chest x-ray to make sure you didn't have active signs of active TB, and then you go on the antibiotic for a year, roughly, which has some downsides to that too. Clinical presentation of the actual disease is very classic: chills, fever, fatigue, chronic cough, weight loss, and particularly night sweats. And not just like when you have the flu, or you have even a pneumonia, and you have an active infection, you're running a fever, and you often would have night sweats, but that's very short-lived. We're talking night sweats that occur every night for a while. Also then hemoptysis, coughing up bloody sputum. Now, index of suspicion, when you go on a scene, if someone's sick, if they appear to be chronically ill and sick, or really old and sick, or if they, if you have a high suspicion of them being sick with tuberculosis, put the patient on a mask if you can. If not, you wear a mask. This is totally airborne. It's totally okay then, and of course you'll have gloves as well, so. And then we will, if they get transported to the hospital and we get a positive tuberculosis on the patient, they'll let you know that, and after that time, it'd be worthwhile to get skin tested or to get a gold test. Pneumonia. Okay. Sometimes it's very hard to differentiate pneumonia from congestive heart failure because the characteristic of pneumonia is inspiratory crackles, rales. Characteristic of congestive failure is inspiratory crackles, rales. So how do you differentiate an infection from a non-infection? Well, most of us will have a fever or have symptoms of an illness. They may have a history of congestive heart failure in the past. If you look at their drug list and they're on Lasix and digoxin or Lasix and a couple of other different, they're having heart medication, you can say, likely more congestive heart failure than not. If they don't have a fever, they may be septic from their pneumonia. So, thing is, your initial emergent treatment is not going to be too much different. High flow oxygen, and maybe if they're having difficulty breathing, CPAP, respiratory care. So, community-acquired pneumonia is just what it says. It's the pneumonia that's in the ambient pneumonia that's in the population. And usually the severe ones are viral or pneumococcus, streptococcus, strep pneumonia. Now, strep pneumonia is a fascinating bacteria because it can do lots of things because of its antigenicity. It's quite antigenic, but it can, if you don't have an adequate immune response, it can very rapidly go to sepsis. So pneumonia can become strep pneumonia, pneumococcal pneumonia goes to sepsis in the immunosuppressed person. So the person who doesn't have maternal antibody, like so a small child after the age of about 6 months to about 2 months doesn't have adequate resistance to pneumonia, so they can become septic. An older person, so beyond 50, we began losing our our active, we become less immunosensitive or immunocompetent, and so we're at risk for pneumococcus. So we get the vaccine, pneumococcus vaccine, which just boosts that. Signs of pneumonia: onset of chills, fever, dyspnea, pleuritic chest pain, cough, and it says adventitious breath sounds, i.e. rales and rhonchi. In a geriatric patient, maybe altered mental state and sepsis. In a little child, maybe sepsis. They will have a history of having cough and fever, etc. to start with. Now, in geriatric patients, they also often have the flu and then go on to pneumonia. And the flu, it may be a viral pneumonia or it may be secondary pneumococcal pneumonia. So, personal protective equipment, management supports oxygenation and ventilation. Consider TB then, so have your own protection. Put a mask on yourself or the patient. Now, pneumococcal pneumonia is not very contagious to you because you have immunity to it. If you get it, you're going to get pneumonia. You're not going to go to sepsis probably. But it's not very likely to get it, especially if you use routine precautions. Routine vaccination is not necessary. Most pneumococcus is now drug resistant, so to the penicillins and cephalosporins, or at least 40% of it is. So we usually treat pneumococcal pneumonia with 2 drugs. Pneumococcus is also interesting because it can cross the blood-brain barrier, so it's the most common cause of bacterial meningitis right now. So, and we always treat that with 2 drugs to make sure you kick it. Chickenpox, the varicella virus, or the zoster virus. Chickenpox, commonly thought to be a childhood disease. We used to have, when I was a kid, they used to have chickenpox parties. One kid got chickenpox, the moms would say, oh, well, let's bring them all over, because they said, well, it's a kid disease and you should get it when you're a kid. Well, it turns out that that's not necessarily a good practice, because first of all, the pretty little kids end up always the ones who get the most chickenpox scars, and the homelier ones, like most of us, didn't get that much scarring, so it was no big deal. And some kids get really sick. And the problem is some moms and some dads who now are exposed to chickenpox get zoster because they had it before, chickenpox before, or they get or if they're immunosuppressed at all, they get chickenpox pneumonia, which is pretty deadly, actually. So we don't like chickenpox that much. Respiratory, chickenpox starts out like a cold. You have respiratory symptoms and a malaise and a low-grade fever, and then you get the rash. But you're contagious about 24 hours before you get the first pock. But all that stuff in the pock is totally contagious because it's viral material. And so some kids don't show much, or they always have a runny nose, cold-like symptoms, and so you didn't pay any attention to it, and so the first thing that shows up is you get the rash. And then it may be very limited, or it's all over. And it occurs even in the scalp. Transmission is airborne droplets and direct contact with lesions. So you get it coming and going. You get it wherever. And in the immunocompromised adult, it can be deadly. It can cause chickenpox pneumonia, which goes on to sepsis. So if you have the past history of chickenpox, you've got essentially a lifelong immunity, except your immunity begins to dribble off as you get to be an older adult. Not all the time, but some older adults don't hold that immunity, the full immunity. So immunization is now routinely recommended for children and adults. We can test for chickenpox titer, but once again, it's expensive. It's much more simple. If you haven't had chickenpox, it's much better just to get the immunization. So standard precautions. Remember, it's airborne and droplets, so gloves and facial covering, mask, eye covering. If you hadn't had chickenpox, if you got a super exposure, you can get post-exposure vaccination, and your vaccination will take hold before you get the symptoms of the chickenpox. Now, after age 50, some of us, your titer, it's either a decrease in your titer or a decrease in your general resistance to, and immunization or immunity to things. You can get, if you're exposed to chickenpox, you can get shingles. Shingles is usually one nerve root is involved with it's a rash. It's extremely painful, so much so that it's difficult to breathe if it's involving a chest thing. A lot of people will come in. I've had patients who came in with severe. They're sure they had a kidney stone again, and so nope, your urine's clean, but that rash on your back is where this is all coming from. It's extremely painful. If you get facial shingles, it can involve the branch of the ophthalmic nerve, and it can cause some lung. And then long-term wise, a lot of people, about 10% of people who get shingles get post chickenpox or post-zoster neuralgia, continual pain in that nerve root. So it's worth not getting it. It's all covered by, it's one of the things that Medicare pays for when you get to Medicare age, because because they know that, and most health things will pay for it if you're over 50 because it's cheaper in the long run. Meningitis, inflammation of the meninges, which is caused by a variety of pathogens, most of which in this area are viral, and it's really not meningitis, it's viral encephalitis then. Bacteria, the most common bacteria in this area is strep pneumonia. I haven't seen a case of meningococcus meningitis transported by ambulance in this county in probably 8 to 10 years. Now, we used to be extremely common. We'd get 20 cases a year at one time. And that was, really a big thing to worry about prophylactic treatment of exposure. Now, a lot of things involved in transmission of bacterial meningitis, particularly host resistance factors. Even the weather occurs in cooler times of the year. You should be in contact with oral secretions because it comes out and it can be done bloodborne, but mostly it's oral secretions. And then close crowding, classic meningococcus is called Fort-Ord fever because they had a couple of big outbreaks with in the barracks at Fort-Ord, California, of meningitis, and they thought, well, it's just all due to the crowding, and it's also due to fairly young people. They were recruits. It's a strong association with smoking. Interesting enough, I don't know whether it means more oral secretions or what, but close contact and so if you're sitting in a barracks playing cards and smoking cigarettes and sharing your glass of bourbon, don't do that. Clinical presentation, it's a fairly long incubation period, 4 to 10 days. As early as 4, but as late as 10 for most types of meningitis. Starts out with fever, chills, classic infection, headache, nuchal rigidity, stiff neck, hurts to move your neck, arthralgia, lethargy, malaise, then altered mental status, vomiting, seizures. Brzezinski and Krennic sign are just variations of the same thing. They're neck signs, meningeal signs. One is when you flex the neck, people have a tendency to pull up their knees to sort of release pressure on that. And the other one is you lift their legs straight up, they flex their neck to reduce that pressure, or that stretch. You don't have to write that down. I don't want you testing the person that much. Immunization now for meningococcal meningitis occurs. It's very effective. It's recommended for all kids and at risk. They generally give 2 shots, one at about 12 years of age and one just before they go to college. Well, so college age. And still, I mean, the last cases that I'm aware of are in Oregon occur. There was at Oregon State, there's been 1 or 2, and then at Oregon, 1 or 2 every year, kind of thing. Now, for you, when you see a sick person who's showing fever, chills, stiff neck, arthralgia, decreased mental status, okay, please use your universal standards. You go in to see a sick person, I want you to have gloves, mask, maybe not necessarily a gown because but you need to take care of your clothes at that point too. And then post-exposure, if you really have an exposure, an inadvertent exposure, we will test that person, the source patient in the ED. They're going to get a blood culture, which is usually positive. If it's positive for meningococcus, it'll be positive within 24 hours. Or we'll do a spinal tap and get a smear, and that should be, we should know that answer within hours of getting there, within a couple of hours. If it's gram-negative diplococci, that's meningococcus. If it's positive for meningococcus, then that's exposure. Then you need, if you really had an exposure, you'll get spanked by me first, and then you'll just get a couple pills. Now, if this is your second exposure, we'll give you a shot. No, we won't. And so, have I had to write that prescription for you or have the ER give you a prescription? Not in the last 10 or 12 years, because people haven't had the exposure most of the time, and if they did, it turns out that this is not a contagious disease to you. Strep pneumonia, meningitis pneumococcal meningitis is not contagious to you unless you're immunosuppressed, and you probably shouldn't be working if that's the case. Now, influenza and the common cold, virus infections. They mutate. They have various degrees of virulence. As like I said, the H1N1 started out being a really nasty virus, and it suddenly mutated and became a very, just a pussycat. It was a very mild thing then, and very low contagious rate. But they come in epidemics, and you can't guarantee it. So we have to be aware of these. Symptoms of viral infections, influenza and cold, they have a common characteristic: fever, chills, malaise, muscle aches, nasal discharge, mild cough. Then they get a secondary infection. Now, the really virulent forms are actually nastier on younger people than they are on older people. There's an advantage to being old in that my immune system is not as aggressive as it used to be. When you're young and you have a particularly immunogenic virus, like an H1N1 of the virulent form, they can, the host, a young host, can mount a really aggressive response to that virus, and sometimes it's an over-aggressive response, and it starts to act like an autoimmune disease. So a lot of young people were going on and getting severe respiratory distress, adult respiratory distress syndrome from the virus because their immune system was too good. And these are the ones that were going on ventilators to get them through that. Secondary infections occur in particularly older people, but the influenza will become bacterial pneumonia, and and then go on to sepsis. So management, your management of the patient is treat what you see. If they're in respiratory distress, they need oxygen and they need support, and you need personal protection. If they don't need anything special, put a mask on it if you're transporting them. You know, not everybody needs to go to the hospital, but that's another story. And then get immunized against influenza. Norovirus. Virus, most common cause of gastroenteritis. Norovirus is, you know, it comes in huge outbreaks. The holiday cruise ship, the entire cruise ship got it. They renamed it the Ship of Stools. And I know. And it's epidemic because it spreads by fecal oral contact. It gets on your dishes, it gets on your implements, it gets on surfaces. Nobody washes their hands that well, turns out, and it really spreads it. So anytime we get outbreaks in nursing homes, people that are trapped together, nausea, vomiting, often explosive vomiting and diarrhea, abdominal pain, chills, fevers, malaise. It's very virulent. So, and we actually are the people that first start this the ball rolling that there's an epidemic. So when fire and AMR get called out a couple times to the same place in the same day, that goes into first watch, and that begins to do a ticker, and we say, hey, there's probably an outbreak going there, and you get notified. But whenever you go into the SNF or a place and they say, yeah, we've got a couple of sick people and this one is really sick and they've got these symptoms, just assume that it's a contagious disease and do your protective clothes. Now, they may be so sick that you have to start an IV on them, give them fluids. They probably don't need to be respiratorily managed, but if they're vomiting, you have to be aware that you could get exposed that way. Measles, highly contagious. We know that we're sort of the poster child for the West Coast, Clark County, for last year. That made public health very excited because they really got to do some work. Highly communicable disease, viral infection, has lifelong immunity after the disease, but not as lifelong after you get the measles vaccine. Transmitted by airborne droplets and direct contact. Starts out as a cold, severe cold, fever. They've also got conjunctivitis, a red eye, inflamed, itchy eyes, photophobia, lights bother you, cough and congestion, but it sounds like a bad cold. Then it gets the rash. So the bad cold symptoms precede the rash by about 2 days. So you could be exposing people all the time. Management is, for the patient, treat what you see. You need personal protection, that's it. You should be immunized. Immunization, if you're exposed and you're not immunized, you can get the immunization, the vaccine, and if you get it within the first day or so of your exposure, couple days at least of your exposure, you won't get the infection. It'll suppress that infection. You'll beat it by your own immune system. Mumps, virus infection, childhood disease, usually thought to be transmitted again by oral droplets, direct contact with saliva, occurred classically in the 5 to 15-year-old patient. We have immunizations for it now. You probably got it as a kid. Primary symptoms are cold-like symptoms and then painful enlargement of salivary glands. The cold symptoms are very minimal. It has a predilection for this type of, for the salivary glands, and usually the bigger gland, usually a parotid gland, sometimes a submandibular gland, but usually the parotid, the one that's right here below your, angle of the jaw. And it's very tender. Moms used to do a simple test. If you had the mumps, they'd give you a pickle. Eat a pickle or bite into a dill pickle, and that causes the salivary gland to contract, and it would really hurt. And so they say, oh, he's got the mumps. Hurts to swallow, hurts to chew, but it's not swallowing like it hurts on one side generally. It's very uncommon to get bilateral. Now, mumps got very bad press, and really, they really developed the immunization for it quickly, because it turns out that the testis is similar in structure and in glandular makeup as the salivary glands, and so every so often a kid would get the mumps, and he'd get the mumps in a parotid gland, but also get the mumps in one testicle, and that testicle was dead from that point on after the mumps thing. And so, being that most virologists are males, they decided that was a very good thing. So we developed the mumps vaccine very quickly. Rubella. So, German measles versus the regular measles, or the English measles, I guess. Rubella is another simple virus thing, and symptoms of sore throat, low-grade fever, and then followed by a fine pink rash. And that's about it when you get it. So we don't really get excited about people with the measles, except that if you're pregnant and you get the measles, rubella, German measles, the child has a high risk of all sorts of congenital defects, from hearing loss to other facial and airway structure illnesses and mental deficiency, all sorts of bad. So you don't want to get it if you're pregnant. So the real risk for measles is to have, for German measles, is for pregnant females. So we immunize everybody to try to basically knock the disease out, so that you don't have that issue. RSV, viral infection, common cause of pneumonia and bronchiolitis. By definition, bronchiolitis, little bronchi. In other words, it's kids. So although you can probably get a cold or a cold-like symptoms as an adult from RSV, you don't usually get anything that's very significant other than a cold. For an adult, it's a cold. So a child, though, can get a severe lower respiratory infection, usually occurs during the winter time. So we're about ready to get into RSV season. The kids can really desat quite a bit, and the usual treatment for RSV is pretty straightforward. If they have wheezes, you can use wheeze medicine on it, okay? Otherwise, increase their O2, and because they have children are obligate nose breathers, so when they have a runny, snotty nose, they really need to be suctioned suction out the nose. That's primarily the treatment we do for it. Pertussis, whooping cough, one of the other childhood diseases that should have been wiped out, but are not because people have stopped doing immunizations. It's a bacterial infection, not a virus for a change, and the symptoms are extreme runny nose, paroxysmal cough, and just an upper respiratory, and then it goes away except for the cough. And the cough is it's called paroxysmal because it comes in waves and you can't stop coughing. And at the end of this coughing spray, you have this inspiratory whoop, which is hence the name whooping cough. Adults who haven't been adequately immunized and who get the disease are usually not terribly harmed by it, except they're sick, but it lasts, the cough can last for weeks and be very wearing, but and also you can still be somewhat contagious during that time period, at least for the first 2 to 3 weeks. But little kids, they basically, little kids can die from the whooping cough because of the respiratory fatigue. You treat anybody who's got a severe cough and who has low O2 sats with increased oxygen and maybe some humidified oxygen, and transport them. We take care of them the rest of the time. But you should be immunized and your kids should be immunized. The problem with pertussis immunization is that the anti-vaccinators have done quite a bit of damage by telling that that there's problems with the pertussis vaccine, and that is not true, and it's entirely different than it used to be anyway. But it is not related to autism. There's no science in that at all. Tetanus, the other one of the other thing of the DPT, prolonged contraction of skeletal muscle fibers caused by tetanospasmin, which is a neurotoxin produced by an anaerobic bacteria in Clostridium tetani. Now, tetanus is one of the bacteria that produces spores when it doesn't have a common way for it to be spread, or a really suitable host or a suitable environment. It goes into a spore form, and the spore form can last for years, if not decades. It's also a common bacteria. It is a normal flora for the gut of the horse, particularly living in the upper intestine of the horse, and therefore all horse manure is potential for having Clostridium tetani. And what do we like to use in our gardens and for fertilizer, and we like to use manure. I don't think it occurs naturally in cows, but in horses, yes. So it's very common in Western society because we have a lot of horses. Tetanus around a lot. It occurs almost exclusively in people who are unvaccinated or inadequately immunized. You need your 3 shots as a child, and then a booster in young adulthood, and then a booster maybe. And we give a booster if we're not sure about your immunization. I mean, when your last shot, we give a booster if you have a deep puncture wound. Otherwise, it's good for at least probably 10 years, at least. Now, in World War I, the most, other than being blown up or shot, the most common cause of death on either side of the conflict was due to tetanus after an open injury. In World War and in the U.S. Armed Forces, we had, as I recall, somewhere in the neighborhood of 500 to 1,000 people who died of tetanus from their wound. In World War II, after immunizing everybody, that's where the immunizations really started with World War II. There was one person in the U.S. Armed Forces that died of tetanus during World War II. Big difference. Spores are mostly introduced through puncture wounds or deep wounds. Also can occur in contaminated injectables such as heroin or other things. CDC says get your booster every 10 years, but if you come in with a puncture wound or you're going to go to surgery because of your trauma, you'll get a booster on the way to surgery. Sepsis. Okay. Quickies on sepsis. Leading cause of death in non-coronary ICU. So in the non-cardiac ICU, it's the leading cause of death. Looking at our own statistics, we have approximately 3 times more patients that we think is sepsis that's transported code 3 than the STEMIs or the severe respiratory distresses. So it's probably the most common cause of us transporting somebody to ED right now is sepsis. Third leading cause of death overall in the United States. So we get cardiac and stroke probably beats them any time. So 1.6 million Americans every year with sepsis, much more common than heart attacks. I just said that. Claims more lives than any cancer, claims more lives than trauma. Mortality rate is the same as breast cancer and lung cancer combined. $20 billion in hospital costs in 2011. So, and that was cheap money. We're probably much over that now. What do we think? What are your criteria for someone you think is septic or septic shock? So, a known or suspected infection. So you see someone with pneumonia. You walk into the nursing home's room for the patient who is not functioning as well as they said they did a year ago or last week, whenever they last noticed, and you think the patient has an infection because you smell urinary tract infection as you walk in the door. And that happened to anybody ever? Temperature, so known or suspected infection with a temperature greater than 38 centigrade, which is 100.4, or less than 36, which is hypothermic, 96.8, and either respiratory rate greater than 20 breaths per minute, or heart rate greater than 100, or an EtCO2 less than 25. Now, why would we look at EtCO2 now? First of all, it's easy to do. Just do a side draft EtCO2. It is the surrogate marker now for acidosis. So, I mean, they could be EtCO2 of 25, and they could be a diabetic ketoacidotic. But diabetic ketoacidotic won't have a temperature or won't necessarily have a heart rate greater than 100. Might. But if you have fever, and ATCO2 less than 25, it's probably they're blowing off CO2 to drop their acidosis, lactic acidosis. Yeah.
Why do you say less than, should it be more than?
Nope. Less than, because they're blowing off their CO2.
So they're hyperventilating.
They're hyperventilating to blow off CO2, which is, that's the only way they can get rid of acid. They can't get rid of lactic acidosis. The only way they can change their acidosis is to blow off CO2.
Should you be more concerned if they're ticket in the presence of like
Elevated what?
like CO2 levels? I've had some pretty decompensated sepsis patients where they're tachypnic, but their end tidal's still like 35, 45.
Well, I'd be a little concerned about that, yeah, because they're probably not being able to compensate. It's a compensatory mechanism. So you need two of those things at least, and the suspicion that they've got an infection. So if two of these are positive, so suspected infection plus any two, and their blood pressure is 90 or less, or they have altered mental status, call the receiving facility and say, this is septic shock alert. If they don't have low blood pressure, or altered mental status, transport them and just tell the nurse, the doc, as you're signing them in, I'm really suspicious they have sepsis because this and this and this. But it's not a septic shock alert. Septic shock alert, you should be met by the nurse and the doc as you come in the door. And they probably want you to put them in a room that, you know, until they sort out what's going on. So, OSHA requires the following immunizations. It's really basically required. Hepatitis B, and this is not for everybody, this is for healthcare workers and EMTs. Hepatitis B, Tdap, tetanus, diphtheria, and pertussis. That's to differentiate for the DPT. The Tdap is the new version, which is, so the pertussis is handled differently. It doesn't have the same diluents in it. An annual flu and polio. Now you can opt out of the annual flu. You should have your polio vaccine though. Anybody here didn't have a polio vaccine? That's one of the things that most parents didn't argue about. They didn't really want to have a kid with polio. When I was a kid, that was a very it was a very big scare all the time that, you know, particularly in the summer, anytime you come home from playing all day and say, gosh, Mom, I feel tired. She'd take you to the doctor so he could check you to see if you had polio. You know, they were so anxious about it. Then we got the vaccine in the mid-50s. Recommended immunizations. I always recommend hepatitis A. Not because hepatitis A is a bad disease, that it's not going to kill you, it's just going to take you out of commission for a while. And you'll probably give it to your family too. And you can get it from eating things. And also I've had mine because I like to eat raw oysters, and oysters are saner, you know, they're filter fish, so they have a tendency to have more things like that. And so now I eat oysters without worrying about it. Measles, mumps, rubella, they're not absolute, but you should get them. You should get them not only for yourself and your family, but you should get them so that you don't give it to somebody else, ultimately. And zoster vaccine, I would certainly get it if you were exposed, even if if you're beyond age 50, get the zoster. And I have to admit, I'm a little anxious about it. I got the zoster. My last zoster was about 3 years ago, and it was very easy, and it's supposed to be good for 10 years. But they're recommending that everyone get the new zoster, of course. And the new zoster is 2 shots, and I have yet to meet anybody who got that who didn't get sick as a dog after both of the shots. So hopefully they'll come out with another one by the time you guys need it. So your protocol for pre-hospital exposure. You think you've been exposed. Notify appropriate agency personnel within 30 minutes of exposure. Don't wait. Upon arrival, notify team leader of exposure, and then per infection control, we will follow prophylaxis and treatment, but we like the important one thing for you to get. So if you think you brought in somebody who you think might have meningitis, tell them they'll contact you as soon as we get a confirmatory thing as to whether this is viral or bacterial and whether it's meningococcal or not meningococcal. You don't need anything beyond that point. They'll go through we'll get in touch with you. If you think you got exposed to body fluids, the source patient needs to get tested then, rapid HIV test and other tests, and then you go from there. Unknown exposures, we may call you from the hospital saying, okay, we now have we have tuberculosis in this. They'll contact your agency and we'll go through who was on that call. An exposure is exposure to body fluids in the body openings, mucous membranes, cuts, and wounds. It's not, I was in the room with the patient, I was fully donned and fully protected. That's not an exposure. You need to be aware that viruses and gastroenteritis bacteria lead to calls from senior and long-term facilities. Wash your hands. There's a reason that classically doctors don't get colds and flus as much as other people is because we used to teach them to wash their hands a lot. I don't know that they do that as much anymore. But we wash. You notice the first thing you go in the ER now, they've got things to do hand disinfecting all over the place. You're supposed to wash your hand. We're supposed to wash our hands when you go in to see a patient. Wash your hands before you touch them. Put on gloves, do whatever, and then you examine the patient. You take your gloves off and you wash your hands when you go out. Assume that patients are always potentially contagious, so gloves, masks, and gowns whenever you're going to have an exposure to blood or body fluid. All EMS providers should be immunized annually against influenza. The vaccine is safe, it's good, and for working age adults and healthy adults, it reduces the risk of influenza symptoms even if you get the disease. Worst case scenario is it cuts your risk in half. Now, some years are better than others in that the CDC gets a lot of really smart people together and they figure out what is going to be the likely viruses and virus mix in the population for the next flu season. And they usually put 3, sometimes 4 different viral strains in that concoction. Sometimes they blow it. Get a lot of smart people together, sometimes they can't figure it out. But remember, the viruses are mutating so quickly that sometimes they really do change. So worst case scenario, the worst batch we've ever had was about 50% effective. Now it's much better. And for us older people who don't have quite the immune ability, they've now increased the senior vaccine amount, not the amount of, but the amount of antigen in it, so that you're supposed to get a better mix. I've got mine already, so I'll tell you how it worked out. During flu season, we wait for the Clark County public health to declare that we've hit the magic number, which means flu season is on. Right now, there's a very low level of flu. When we get to, I think it's 12 to 15%, they say, uh-oh, active flu season. And that's reported cases. And then we're in full flu season. During flu season, you just follow your standard. If you've had your vaccine, you just follow your standard infectious disease procedures dealing with patients. But if you're not vaccinated, if you've elected not to be vaccinated or you just forgot or whatever happened, you follow your standard vaccination, your standard infectious disease processes with the patient, and then wear a mask during any patient contact, entering an enclosed space containing sick patients, whether it's private residence, SNF, clinic, patient transport vehicles, or entering all hospital facilities. Obviously, you'd be wearing gloves too. Other infectious disease, rare, quickly through this because we don't see, I'll tell you in a minute, you don't see it. So it's the Zika virus was the big thing about 3 years ago. For 2 years, it was a really big thing because it's through the bite of an infected mosquito, and the mosquito is the Aedes aegypti, and the Aedes albopictus, which is, there turns out to be a whole bunch of different mosquitoes out there. And it can be transmitted maternally to the fetus. It can also be transmitted via sexual contact. So you get the disease and then you can transmit it. So, and it has bad effects on kids, birth defects. And the biggest one is microcephaly, small heads and brains. Now, the symptoms of Zika infection are very mild or nothing to a fever, rash, muscle ache, conjunctivitis, sort of like any virus thing, and it's self-limiting. It goes away, so you don't think about it. In 2016, there were 137 cases, and it turns out that other mosquito, this particular mosquito is common in the south of the United States as well as in Central America and South America. So in Florida, there were 137 cases in 2016, all in the state of Florida. But in 2018, 2019, there's no reported cases, although you can still get it if you travel to South America, Africa, some places in India. Even France has mountainous areas are more common. That's where the virus likes to live. Prevention is prevent mosquito bites. Long sleeves, cover up, and DEET. Ebola. Four of the identified viral species of Ebola can cause disease in humans. It was discovered first in 1976 in the Congo near the Ebola River, hence its name. The most recent outbreak last year, it's still going on now, but it started in last year in the Republic of Congo again. There's been about 1,600 deaths so far. However, there is now a World Health Organization approved experimental Ebola vaccine. It had 97.5% effectiveness last year for the general. So if you hadn't been exposed yet, or if you were, at risk, so far 97.5% effective, which is about as good as you can ask for. Direct contact through broken skin or mucous membranes with blood or body fluids, or objects like needles and syringes. Also from infected animals, African animals, the sort of host reservoirs are bats and monkeys. Only symptomatic patients can transmit the disease and is not airborne, despite Outbreak, the movie. So we ask, and you may ask, you'll see this on some of the, when you go to the hospital or when on CRESA, they will ask patients these questions when they're real, do you have fever, chills, headaches, weakness, fatigue? Have you been, in the last 21 days, have you been in areas where Ebola is? They used to ask about West Africa, but they stopped. Now they say, have you been in areas where Ebola is active? Because people don't know where West Africa is. You ask people that India is part of Africa or whatever. So we just ask them if they've been where Ebola was common. Have you been in contact with anyone? So, blood and body fluid precautions, and don your PPE per protocol. We go through, when there's an outbreak, you go through the whole doffing and donning protocol. The super protection. It's basically a hazmat exercise. And we have not had any, I'll let you know if we have any Ebola that surfaces, but we don't have any going on right now. Have to be very careful if you have to do an invasive procedure on a patient. And that includes IV, suctioning, airway, etc., or even nebulized medications. CDC will provide most information. Ebola exposure is very rare. The exposures in 2015 were due to lack of awareness and preparation. It is not airborne and requires direct contact with body fluids or with droplets. Lyme disease, I threw that one in just because you guys, some of you go out hunting, some of you go out camping and hanging out. It's transmitted to the humans through the bite of an infected blackleg tick. The blackleg tick is the one who mostly hangs out in the host, or the reservoir is in rodents and deer, particularly white-tailed deer, which live on the East Coast mostly. Starts out with fever, headache, fatigue, and a characteristic skin rash called erythema migrans. It's a bullseye rash. So it's a red rash, a reddish circular kind of thing with a blanched center, like a bullseye target. If left untreated, the infection goes to joints, to heart, to nervous system. It can cause all sorts of things. All sorts of it. It's very easily treated with antibiotic. But you should catch it at the time you have the bullseye rash. Treatment is a couple of weeks, and the little black-legged ticks are just as bad as the others. Ticks are not very big. This is a quarter, and it's not very big. Prevention, insect repellent, removing ticks promptly, and you got to get the mouth part out too. Can't just rip this thing out. Applying pesticides, reducing tick habitat. Okay. So we have some case reviews somewhere here. Yeah, I can't close it. Don't know where the close is on this one.
It's that one right there.
Yeah. Okay. Okay, here's an 80-year-old female at dialysis clinic. According to staff, patient complained of chest pain, shortness of breath, was given nitro, placed on O2. Patient had not received any dialysis treatment today, the day of service, had not missed any recent treatments that they knew of or they couldn't remember it. Patient couldn't speak, so not able to tell chief complaint. Upon arrival, sitting in a dialysis chair on a nasal cannula, appeared to be moderate respiratory distress. Prepping to place patient on a simple mask with a duoneb. SpO2 was placed while lung sounds were listened to. Lung sounds show wheezing and rhonchi in all fields. So SpO2 is below 50, so it was switched to CPAP. Placed on patient. As CPAP was being set up, patient started having more difficulty breathing, went into a hypoxic seizure lasting about 15 seconds. Placed on the ground, had agonal breathing, now unconscious after the seizure. IGL 5 was placed with no gag noted, bagged with ease. Bagging got harder as time went on until RSI. IV was established, patient placed on gurney. Rock was chosen over sucks due to potential hyper K. Reasonable choice. Prior to tube placement, the patient reached for the IGL, couldn't remove it from the airway. RSI meds were pushed. Firefighter intubated after IGL was removed. Upon visualization of the airway, secretions were suction, size 7 tube was passed with visualization of cores, watched the tube pass, etc. ETCO2 placed, patient bagged. Missed in the tube, ETCO2 number and waveform noted with lung sounds bilaterally. Loaded to the ambulance, fentanyl is given to keep patient comfortable, vitals monitored, no change en route. Taken room transferred to ED before transfer. LP15 was printed to confirm tube was still in place. Patient was transferred to ER bed and report given. Okay. Preston, I think you reviewed this one. Okay. Well, the nice thing about this, so when we say both charts, we mean both the AMR and the Vancouver Fire chart are excellently done. VFD narrative does a great job of describing how the patient presented, what the clinical scenario was, and how things progressed. The idea to go direct to the IGL was smart, and a smooth transition was made between non-invasive attempts to the eventual ET tube. This type of patient has the potential for arrest during the intubation attempt, given the bad baseline health and initial significant hypoxia, but this was a very smooth process on scene that made this happen without incident. Ideally, and we're going to be dealing with this starting the first of next year, we would like to see better SATs pre-RSI drugs and bagging with PEEP as well as nasal cannula going at 15 liters, but sometimes this isn't possible due to a lot of things. Again, intubation procedure went very well. Described in the narrative leaves little to our imagination because you guys don't want to let us imagine, because we always imagine the worst things. AMR chart reiterates and summarizes from their perspective well too. Choice of rock was a good one. These are good examples of how we want to see the RSI documented, and Dr. Fedor has just recently completed a format for an RSI form that we're going to ask to be, well, we'll be in-servicing that later on and try to get that into your chart to help us be able to quickly pick out the important things from the intubation. In hospital, she was 80 years old, had diabetes, hypertension, end-stage renal disease, acute hypoxic respiratory failure. She was fairly quickly resolved, extubated after about 24 hours treatment. She had dialysis. It was suspected that she really wasn't keeping up with her medication, that she probably had missed some dialysis that she shouldn't have. She had paroxysmal atrial fibrillation with RVR, which is common. She's, at any rate, her mental status has improved. She recalls having an angiogram in the past, but she was going to go off for repeat angiography because she had some elevated troponins and possibility that she might have had a slight MI. Number 2, 50-year-old female, short of breath, diagnosed with pneumonia 5 days ago. Friend on scene said the patient was prescribed clindamycin and an unknown steroid for treatment of pneumonia. States she'd been experiencing shortness of breath the last 2 days. States she felt like her throat was swelling. Patient friend on scene stated patient's face appeared to be more swollen than normal on the right side. Says she'd been intubated in the past because of her asthma. Past medical history, pneumonia, asthma, insulin-dependent diabetic. Medications as below, there's a lot of different things. She's got Humulin, lisinopril, Lasix, metformin, amitriptyline, Medneb, albuterol, and Atrovent given. Patient able to ambulate with minimal assistance 10 feet through narrow corridor to gurney, secured to the gurney, and transferred to medic unit. Got some Benadryl IV, some Solumedrol IV, an Epidrip was started. Code 3 transport. Intubation equipment was set up. Patient continued to deteriorate during transport. Stated she was getting too tired to breathe. Head was bobbing up and down. Asked if she wanted us to breathe and said yes. Pre-oxygenated the patient with high flow O2. Got ketamine. Got succinylcholine. King vision. Patient's tongue didn't appear swollen. Oropharynx below the base of the tongue appeared swollen. Visualized vocal cords with King. Bougie. Visualized insertion of ET tube. Remove the bougie. 5-point auscultation, etc. ETCO2 confirmed. And got some fentanyl, bucking the tube. Got another 100 of fentanyl, bucking the tube. 5 milligram of Versed, continued to buck the tube. 5 Versed, more. Was better by that time. Transfer to the hospital, care of doc. So, QI feedback, also from Dr. Fedor. This went back to the cruise. Case was done quite well. A narrative paints a good picture, great picture of what was happening. Initial evaluation as well how the patient deteriorated over time is clear by the narrative why and how an intubation would perform. The intubation itself is described in appropriate detail and leaves little to our imagination. Remember what I said before. Description of the airway and tongue appearance with the King was appropriate and helpful in establishing possible diagnosis. His only issue was a minor one, which was the dose of sucks, which is listed. It is noted as 172.5 milligrams. Okay, we appreciate that specific calculation, but you can't tell me you can actually draw up 172.5 milligrams. You can fudge, like 170 milligrams or 180 milligrams. You can probably do that. Otherwise, he didn't have any complaints. So, this is acute exacerbation of asthma. Patient also has Haemophilus influenza pneumonia. Suspected paradoxical vocal cord dysfunction. She also had DM2, uncontrolled chronic pain disorder. Hospital course. She was admitted to the ICU with asthma, hypertension, hyperlipidemia, morbid obesity, diastolic heart failure, admitted with acute hypoxic respiratory failure, secondary to acute exacerbation of asthma, along with Haemophilus influenza.
Treated with IV steroids, nebulizers, initially and clinically started on cefepime, a broad-spectrum antibiotic, cephalosporin. Extubated a day later, was on 2 liters of oxygen, nasal cannula, weaned to room air. Got worse 2 days later, then placed on BiPAP, wasn't intubated again, transferred back to the ICU, and she was put on a Precedex drip for her asthma. And then by 10:20, she'd improved, no wheezing, was doing good, and was weaned to room air and went back on the medical floor on 10:20 and went out a day later. Okay, this is this one is a really fascinating case because mostly Camus gets dealt with this one. This is a 14-year-old girl, 85 kilos, complains of difficulty breathing, and she has hereditary angioedema. This young lady's history is she's probably been intubated, I don't know, somewhere between 30 and 50 times in her lifetime. This time was, and I don't know how many calls we've got in Camus on her now, but I think we're probably up somewhere into the 20 to 30 calls just recently. This time called to the school. She began having shortness of breath, difficulty breathing at about 10 o'clock in the morning, and took her rescue med, which is called Firazyr, which is for a specific medication for angioedema, for the hereditary angioedemas, and it didn't work. This is the injection. Didn't say any different. She thought that her own tonsils appeared larger than normal. That should be actually a little hint to me that, why are you examining your own tonsils? And have a, when I'm having a breathing episode, am I going to look at my own tonsils? She's speaking a few words of the sentence whenever she's asked questions, has audible stridorous noises from airway, didn't know any specific trigger, no recent illness, et cetera, and as I said, she's reasonably well known to Camus by now. She's alert oriented, appears distracted by breathing difficulty, seems anxious although not panicked. Vitals were okay. Oropharynx is smaller than normal, no redness noted, just enlarged swollen tissue around opening the oropharynx. Stridorous sound on auscultation of neck with minimal air movement. No wheezes in her lungs, low volume, make it difficult to hear. She's mostly seems to be stridorous. O2 is on the patient. O2 sats are 100%. Blood pressure is normal, heart rate's 119, ETCO2 is 44. Got some racemic epi, which she has had before, sometimes with relief. Began transporting, worked to keep patient calm, gave her some Versed 1 milligram IV. When nebulizer was complete, switched O2 to nasal cannula, remained stable, got to the ED. Relates she doesn't feel like she's improved during treatment of transport. Doesn't appear anxious now, arrived at Peace House Southwest. In hospital, she had been seen the day before in the emergency department by EMS. within the same week, she'd been seen again, and she had been intubated by the ED doctor, transported to her own physician at OHSU Dornbecker, and discharged the same day from OHSU. There's a considerable anxiety component to this, but she doesn't, admit to that or doesn't agree with that. She generally does well with Versed, and so I would probably caution that, that in any case that a little sedation would be good. I don't think a milligram of Versed in an 85 kilo person is anything other than what I would call a homeopathic dose. I'd certainly like more, and I don't weigh 85 kilos. So I don't think that's enough to really affect her or to improve her. Racemic epi is also of questionable value, although if you give her enough, it'll probably hype her up a little bit more than anything else. It can't hurt, so probably with the appropriate dose of Versed, it'll take care of that. It'll match each other out. There's probably no way that we can avoid these calls, because everyone is going to respond to a child who says that they are having trouble breathing. And, it's a long, I think our own physicians are extremely frustrated, and, you treat what you think you see, because I know at least, I think Dr. Fedor, I reviewed her entire chart and at the ED, and I know you've seen her once and said she was doing fine after.
Part of the visit after this one.
Yeah.
She's pretty scary looking, and
Yeah.
she does sound.
Yeah, she's.
Sounds like she has striders, tachypnic, and it's a good story. But
Yeah.
She doesn't have any. At least when I saw her, didn't have any of the objective findings of
Yeah.
angioedema.
Yeah.
Basic color refused to
But,
intubate her.
but several of the ED docs have have been really impressed by her presentation to the point where they drop her and intubate her, transport her, and every time that I can see, she ends up at Dornbecker, gets extubated, and leaves that same day. So, don't know how to get around that. Arrived on scene along fire to find patient lying on right lateral recumbent on his bed, obtunded and drooling with vomitus in the bed. Daughter on scene states he wasn't a drinker, so he didn't drink every day. But after an evening of drinking, approximately 325 mils, now that's pretty impressive too, 325 mils of hard liquor. First of all, that he or she would be able to estimate how much. He became sick and unconscious, and then after which she was called to pick him up and take him home. They didn't like letting him lay around unconscious and drooling. Patient daughter stated she called 911 because he wasn't staying on his side, and she was concerned about him. He's unconscious, unresponsive, had effective respirations, palpable pulses, but the decision was made to RSI the patient. Placed on a sheet, moved to the ambulance, had effective respirations, obtunded, aside from mild acidotic ETCO2, we'll see that in a minute, I guess. Intubation attempts were taken on scene at the ambulance. Placed on high flow O2 for apneic oxygenation while medication supplies and IV access were obtained. Well, he's not apneic oxygenation if he's still breathing. And if he was breathing while you were getting the medication and supplies out. Patient given an induction dose of ketamine, a subsequent paralyzing dose of SUX, which provides sufficient sedation and paralysis. First attempt at intubation was made with a MAC3, stylet cuff tube, limited oral review, mild secretions. The glottis the epiglottis was visualized, found to be severely anterior. First attempt was discontinued due to blade length intubation, and second attempt was promptly done with a Miller 4, and an ET tube was successfully passed. Doesn't say whether they used the bougie. We like to see a bougie on all intubation if possible. If not, tell me why you can't use it. I talked to somebody today that the bougie wouldn't go around the corner, so they used a different stylette. Laryngoscopy is maintained during, and everything was confirmed. Patient transported emergently PH Southwest. Post-intubation sedation and anesthesia given immediately after securing ET tube and were maintained through transport. Also placed on mechanical ventilation. Patient remained hemodynamically stable. Verified by capnography and a significant move. I like having you put that down so that we don't have to look for it. So his ETCO2, they said it was slightly acidotic. I can't find a number there. Oh. Okay. Succinal choline, okay, Well, this is the ETCO2 after he got intubated, apparently. Let's hope it came up, huh? Okay, CO2 value is now 25, so it's coming up. CO2 is now 35 at the bottom, so it did come up. So he was, and there's his 12 lead, or a 3 lead, and et cetera, et cetera. So his ETCO2 ends up at 34 to 30 ultimately. So, excellent description of the scene, patient presentation, indication for intubation, outstanding description of the RSA setup, procedure difficulties, and confirmation. From an airway logistical perspective, a couple of suggestions. Don't know what the outside environment was like, but intubating, it's better, always better to try to intubate on a full height stretcher if possible. Give you better views, make the airway less anterior. If the airway ends up being anterior, then you can always try extralaryngeal manipulation or lifting the patient's head off the bed with the other hand. A bougie is always good. These are minor things. It was an excellently done, they did well with it. It was just that there are ways to make it less anxiety provoking for yourself. He said, so Dr. Fedor said, you clearly recognize the issue with attempt 1 and went right to the solution in attempt 2. So no complaint, just style points. In hospital, discharge diagnosis, acute alcoholic intoxication with delirium. Hospital problems include polysubstance abuse, aspiration pneumonitis, acute respiratory failure with hypoxia. They took care of him. He stabilized. He was extubated within 24 hours. His home medication was restarted. He was stable throughout. He was discharged home. He was treated for a little aspiration pneumonia. His daughter was right. She couldn't keep him on his side, and he kept aspirating. He was advised to stop drinking and taking methamphetamine. All at the same time. Okay. Next month will be skills sessions. It will be involving this. We're working on more airway. One of the problems I'm trying to solve is the patients who are severely hypoxic, usually due to respiratory or congestive heart failure problems. They're severely hypoxic, and it's difficult for us to get them up into a safe intubating level of SpO2, and they end up bradying down on us and or going into an arrest in the middle of intubation. So we're trying to get around that, and one of the ways we're going to do is to move into essentially what's called delayed sequence intubation, which is more sedation and manually trying to assist them in breathing with a PEEP valve and a BVM and high flow O2.
And also this is gonna require, a coordinated team effort, which is one of the things we were talking about today in the little preamble to this, the VFD, medic corral, is that, we need more training together, which I'm trying to figure out how we can best do the medics from AMR and the medics from the fire having joint trainings at least for the things we need to do as a team. I mean, management of a severe congestive heart failure patient who's hypertensive and has an SpO2 of 70 to start with is a team sport, and we have to work together on that. So we'll try to have a plan set up, and we'll roll out our new orders on that at the first of the year. Any rate. So like I say, next month will be skill session again, and then back into the annual things. So have a good Thanksgiving. You know, you can practice intubating on a turkey carcass, I suppose.